Well, good afternoon, everyone. Welcome to this board meeting of Sussex Partnership NHS Foundation Trust. My name is Peter Molyneux, and I'm the chair of the board and of the trust. I have a few welcomes to make this afternoon. I want to welcome Rachel Goldsworthy, our new Chief of Staff, David Triggs, our new Company Secretary. I want to welcome Paul Colbran, who is standing in for Gurpreet Panu, who is away on leave this afternoon. I also want to welcome Dr. Jennifer Eccles, who is, I'm pleased to say, going to be the nominee from our medical schools to our board. Formally, you're observing this afternoon, Jessica, because we've just got a few more of the processes to go through to achieve full appointment. But I'm really glad you were able to join us this afternoon, and I hope you will feel able to contribute to the discussions as appropriate. You're really welcome onto the board. It's great to have you here. In terms of apologies, I've had apologies from Gurpreet Panu, from Nitin Mehta, who's on paternity leave, and from Funmi Onasumi, who has gone home sick this afternoon, which is a shame, but hopefully we'll follow up with her in due course. I'm also had noticed this afternoon that a number of people have got diary clashes this afternoon, so some colleagues will be needing to go to other meetings, but we'll trust that they'll be able to do that at the appropriate points through the afternoon. In terms of declarations of interest, I'm not aware of any new declarations, although we will, of course, record the declarations of new members at the appropriate point. Can I now move us to the minutes of the Board of Directors held on the 2nd of August, and can I seek approval of those minutes? It appears that I can. We haven't had any questions from members of the public. We are continuing to promote this facility both via the Council of Governors and via social media, and we will continue to make it clear to members of the public that they do have this as a route by which they can raise issues with the board. If I could then move to the chair's report, I'll take the report as read. I'm happy to take questions in a moment. One thing I did want to flag is that the board has been looking at the board assurance framework, and we have done an initial review of the board assurance framework, and we will now be bringing that through to December board. It was scheduled to come to this board, but it will now come through to the December board. And I think that then we can make sure that we properly looked at those risks in the round. I hope people are content with that. At that, I'll just take any questions on the chair's report. Joe.
Thank you, Peter. Just picking up on the chairs and chief execs meeting with NHSE, there were three key things which they stress wards need to focus on, and I wonder whether you could elaborate on why those three particular areas.
I mean, I think it's fair to say that this was a day-long meeting, which I was seeking, and it's my summary of what I took away as the three things that they wanted us to focus on. And I think that what I thought was important, that we understood that messaging, and that we as a board were confident that those were issues that we were fully considering, albeit through the lens of being a provider and through the lens of being a mental health and learning disability provider. And I think what we'll need to do, particularly I think around the way in which the public's perception of the NHS is informed by many narratives, including the media narrative. And I think it's important for us as boards to get upstream and think about what in any scenario was the role of the board, and did it fulfill its role as the first line regulator? And I think those three issues of things that the public and the media are concerned about. And that's obviously, there's a bit of an interrelationship there, but one where we as boards need to think about actually what should we be doing upstream of those issues in order to try and generate the right kind of assurance, both for ourselves and for our stakeholders.
Thank you.
Is there anything else on the chair's report and for today? Thank you very much. Chief Executive's report.
Thank you. Hello everyone, I'm Jane Padmore and I'm the Chief Executive of Sussex Partnership Trust. I'll take the report as read and I'll just pull out a few highlights if that's all right. So obviously the industrial action continues and we are working with system partners to make sure that services are safe across the patch, running a sort of Christmas Day level service, and we've been successful in managing to cover and haven't had any untoward incidents as a result. But I think what we will see is some impact on waiting times for outpatient clinics where we've had to cancel clinics for people that are not in the urgent and emergency pathway. Obviously, there's been a lot of the news about Countess of Chester Hospital and the Letby trial and conviction, and I think we've done work within the trust that also fits in with Freedom to Speak Up theme this month of breaking down barriers, of how we support people to be able to speak up. And I've been thinking a lot about how we listen to the silent majority as well as the vocal minority, that we make sure that silent majority who maybe are concerned or have things they want to raise, find it easy to come and speak to whoever they need to, whether that be the Freedom to Speak Up Guardian, whether it be to me personally, other executives or non-exec directors, or whether they want to do that anonymously through the internet, you know, multiple means for people to speak up. But it's more than just speaking up and more than just listening. It's about us actually taking action as a result of that and triangulating with other data and other bits of information we have to make sure we're really focusing in on where we need to make improvements and where we need to really take notice of things that are happening. Obviously, we've just come into autumn. And it's the time for winter planning, and I'd say we are well underway with our winter planning. And at Exec Committee today, we saw our full winter plan, which is I have to say I think it's probably the strongest one I've seen. It builds on our UEC Urgent and Emergency Care Mental Health Improvement Plan that we have in place, and strengthens that. And alongside that, we have the vaccine clinics for COVID and for flu, which is about winter planning. It's about keeping our service users safe. It's about keeping our staff safe, and it's about being able to continually provide services over the winter. And you'll all be pleased to know that this morning we had a vaccination clinic downstairs where all of the executive directors had their double vaccines, so leading by example in that space, and it was painless. For all of you that are maybe reticent of getting it, it was a very good experience. The other thing that we're really thinking about is the sexual safety charter. There has been a lot in the media around sexual safety of patients and of staff, and I want to acknowledge that Peter Aitken was recognised in the sexual safety charter that was published. We haven't yet signed up to it because what I'm keen to do is that we really consider it and we sign up to it in a meaningful way. I think, yes, we want to sign up to it, but I want to make sure that signing up to it means taking action and doing something different. It just doesn't mean putting our signature on the end of a document. So we're going through a process of putting in place a plan and some improvements that mean that when we sign up, it is a really meaningful activity with the appropriate communication around it, that is also speaking to the freedom to speak up and being able to break down barriers. So triangulating all of that. In relation to the system, as is what I say every month, and it is true every month, it is hot out there, it is really busy, and the need in our community is high. And our staff are working really hard. I've been to a couple of crisis teams since the last board, and I've been to many crisis teams before, but it is really stark how busy it is and how stretched they are. And I think when we look at what we are doing, this is going to be a long-term approach to addressing this. Winter plan's going to take us through a critical period, but it's not going to completely change things, and therefore we need to be thinking completely differently. And I've started those conversations with social care. I met with the Chief Executive of West Sussex and East Sussex County Council this morning to really think about, over the next 2 to 3 years, so looking at the medium and long term, what can we do differently to help flow in partnership with each other. So that piece of work's in place. With the shared delivery plan that was signed off by the ICB, I am the lead for Mental Health, Learning Disability and Autism board, and we're on track for the majority of the priority. There is one around community contacts that is not on plan, and I don't think we have a credible plan for recovery yet. But that's because the data, there are some issues with recording of data that we need to bottom out and then make sure we've got a proper recovery trajectory. Other areas where we're behind trajectory, there are plans in place, but I think we need to strengthen them in some areas, particularly around neurodiversity assessments. So I think we need to strengthen our actions around that. In relation to the other work streams, the discharge work stream really took on board the feedback we gave that it was very acute focused. Mental health was not really strong enoughly represented given our medically ready for discharge profile and the need within Sussex for work around discharge, that mental health did not seem to be very prevalent. That was heard very, very clearly, and a new work stream has been developed under the discharge work stream specifically for mental health, and it's being led by Mark Stainton, the Director of Social Care in East Sussex, on behalf of the system, and we're inputting into that. And I feel really positive because I think the issues we have for discharge in mental health are unlike the acute discharge problems. They are different, and we can't just lump them all together because the answers are different. So that discharge is underway. I'm also the lead for the workforce work stream, and we've had our first green, which is really good, where we've actually achieved one of our objectives. And myself and me and Teresa went to the University of Brighton to launch it on Friday, and that is a new initiative where any student nurse that is trained at the University of Brighton that started last week, if they go through our training over the next 3 years and we're signing them off as competent, that is their interview and they're guaranteed a job. So it was met with real positivity from the students. It was a lovely event to go to. It was one of the highlights of my week last week. But it's a really positive that they felt 5 days into their student nurse training, they've been guaranteed a job. And that this 3 years is about finding the right fit for them within the organisation and where they would want to work and develop their career and having a fulfilling career. So setting out our stall from the beginning. And the reason myself, Teresa and Funmi all went to the launch event is to just confirm how important this is to us. And we want to roll that out to other disciplines. We want to roll that out across Sussex, but we're the pilot with the mental health nurses at the University of Brighton. We've had some successes, as you'll see from from my report around recruitment activity. So we've seen a real uptake in recruitment, which is really positive. I think we've still got work to do on retention, particularly people early on in their time with us, and helping them to helping us to think about how how staying here is the thing they want to do and not move on, and looking at their career pathways. And one of the things we are introducing is really following up more proactively over the 2 years. We do it with letters at the moment, but actually thinking about having lunches and breakfast with people and really hearing about their experience. And finally, I thought I'd finish because it does fit with our breakthrough objectives, and it's one of the enablers to our breakthrough objectives. We've said over the year for one of our breakthrough objectives that we want to convert 30 of our vacancies to posts that are with the voluntary sector, that money being transferred and those posts, but we needed the mechanism in place to be able to do that. And so we now have a voluntary sector compact with us that enables us to do that. So in the last 2 quarters, we can actually action that now. And I think one of the really positive things is it really is a partnership. So whereas historically, I think it would have been Sussex partnership with the voluntary sector, we've said the voluntary sector with Sussex partnership. So really thinking about the power balance between statutory agencies and the voluntary sector. And I met the new chief executive of the YMCA yesterday. She had a coffee with me, and really thinking about how we can use the learning from the housing work into the young people space as well, with the 16 to 25-year-old, and really expanding that area of work and building our credibility as a partner of somebody who they want to work with and see as beneficial to their objectives and their aims and ambitions and vision, as well as ours. So it feels like we're really moving into a different space with the voluntary sector as a result of, I think, some really good groundwork that Colin and his team have done, but also the setting it as one of the breakthrough objectives and really putting it at the forefront of what we're driving as a board. Welcome any questions.
Okay, thank you very much. Kevin.
The unmute button. Yeah, I'll start with the VCSE because yeah, I've picked through in detail the compact and I loved it. Unsurprising, I guess. I think there's something about how we evolve that objective over time, though. I understand that 30 is a proxy indicator of where we want to get to, but how that evolves into co-production of models of care, of systems, and it becomes, I know it's a long program, but wonderful start. So thank you for that. The question I was going to ask was about yeah, it is hot out there and there's lots going on and lots of system pressures and lots of internal pressures and change initiatives. And we've got a new divisional structure in place, if you like. So I guess it's beneath the headlines of recruiting to the divisional structures. How's that feeling and how's it going down?
So the divisional structures, we had our first proper round of quality performance review meetings over the last week and a half with the new divisional structures. Obviously we don't have everybody in post yet. Some are still going through the recruitment process and have start dates, and but with those that are there at the moment, we had our first QPRs, and it feels like they are really solidifying as a team, and it felt like they're really talking about their place more. And it was very specific to Brighton and Hove, very specific to East Sussex and West Sussex and specialists when we met. I think the other bit is it's we are having some OD work with the triumvirates, which are the leadership teams with the equivalent in the so John is the chief operating officer, Teresa is the chief nursing officer, and Pete as the chief medical officer, are meeting with the 4 sets of triumvirates in the divisional leads in the divisions the leadership teams on a regular basis with external facilitators to help develop commonality, but also learning from each other and a peer group to support. And that has been really welcomed by the triumvirate because it sets a different tone and it sets a different expectation, but it also shows them that we really value them as a leadership and we believe in them.
A follow-up, Chair, or shall I not? Yeah,
no,
it's just,
no, do.
And I guess the key thing, as you said, is place-based. So it's how much freedom and flexibility over the next 3 years that they have to integrate at place level with the wider structures and making sure that they're enthused and empowered to do that. And I'll stop.
Absolutely. Peter, you had your hand up and you're
yeah.
I don't know whether to invite you.
So So we're likely to get some form of regulation for managers at some point over the next period. And I think there's something about how we as a board contribute to that debate as the first line regulator, and what our role is, and how we contribute through our various trade bodies to that. But I'm also very conscious that we've seen a corporate manslaughter charge brought against an organisation and against a ward manager. And I suppose it's how we work with our staff and our managers to keep, if you like, the focus on quality improvement, but to recognise that the external environment feels like it's changing.
I think you're absolutely right, and it's something as an executive team we've been thinking and talking a lot about. And I think the thing that we've come to is that it's really important to, whether it be for regulatory compliance or, you know, and revalidation as a manager in the future, or whether it be as a ward manager, that we really protect and facilitate reflective practice time and time to think. And that fits with the supervision and appraisal. So and our relatively poor performance in relation to the recording of supervision and appraisal. And we're improving, we are definitely improving. But that question we've been asking, particularly in the QPRs, is there's a reason behind why supervision and appraisal are important. It's not to pick a number and to get a percentage up. It's so that we're actually being mindful of what we're doing, and we're learning and we're developing together, and trying to get to the point of understanding the value of something, and therefore people want it, rather than just doing it because, oh dear, we're at 85% and we need to be at 95%. So changing the conversation a bit.
Yeah. Joe, thank you. Joe.
Thanks. Thanks for raising that, because reading what the initial drafts, I thought initially this was just more regulation and overkill. But I think in terms of managers, I think that compared with other sectors, particularly outside of the public sector, I think the NHS needs to improve the way that it deals with managers' underperformance. Because if the regulation comes in and managers are regulated and you are responsible, or you can be held liable individually and jointly for corporate issues, then one of the key indicators in that will be a trust failure to actually deal with managers' underperformance. And I think that looking at some of our future work around developing our managers and developing our cadre of future leaders, then the ability and having the skills to deal with manager underperformance has got to be high on that list. It's not the culture of the NHS, but it's beginning to look as though you won't have any choice in terms of how you deal with it, because not dealing with it will be an indication of overall failure by a board to manage its leadership team.
Thank you, Joe.
Teresa.
Sorry, what I was going to take the three comments and then let you come back, Jane. Is that all right? I could have made that more explicit. You're absolutely right. Sorry. Teresa.
Thanks. Just to go to Joe's point and Jane's earlier point. So I was really pleased to hear a presentation at the People and Culture Committee recently about a leadership development, in-house leadership development programme. And I think that this conversation spotlights and highlights again the need for organisational development and the resource in organisational development for us. So we, in one of our sessions with Kaleidoscope recently, and then in the exec team, I was saying the more we have, the more we need. And I think that that's going to continue to be a theme as we go through the coming year.
Thank you, Teresa. Dinesh.
Thanks very much. I just wanted to sort of raise a couple of points. I mean, firstly, I agree that if the managers are underperforming, then we need to look at that. But the overall regulation, I'm not sure is going to work, in the sense that, we've seen it in the GMC, following Harold Shipman, GMC kept saying, "Oh, we are going to be light touch," and over the years, I've seen the bureaucratic nightmare, which is about appraisal and control, and problems still keep occurring. So I think maybe there is an opportunity for us to spend some time as part of board strategy to look at what we can do as a group, and then roll it out. Because my fear is that once central regulation comes on, it's going to be it's always a bad case, bad law after a single case. And people think that they're doing all the right thing and there will be no more future Lucy Letby's. There will be. The question really is, how do we create an open culture within the board where people can express their concerns, even if it is, it's just sharing what they're observing and what's going on, and the board and the line managers that have the power to look at and change things as they need to be.
Yeah, I mean, I think I think everyone's right that there's two bits to this. There's one, there is the debate about what might come, but I think there's what we can be getting on with now to actually feel that we are doing the right things within our own organization to make sure that we do have the right culture as well as the right quality management system, but also to prepare for what may be coming down the line. So that I think, Jane, is where we are, and I suppose it's just yours and the team's thoughts about what we need to do, both in the short term and the medium term, to feel we're in the best place we can be.
I think you're right. There are two bits, aren't there? And I think in terms of the wider question around regulation of managers, to be honest, I don't think there's anything to. I think we need to influence that. Yeah. But I think, as a nurse, I am still a nurse. I still revalidate. I value my revalidation. It's my time to reflect. It's my time to grow and learn. And I don't think there's something to fear from regulation of managers. But if we don't input into making that meaningful exercise, I don't think it's a question of should we or should we not. It's about whether it's a meaningful exercise, and being able to put input into it being a meaningful exercise. And then it takes you to the second bit of what you're saying, Peter. So what does that mean for us? So for personally, for me, my revalidation is next year. I've already set up my process to revalidate, and I'll be using the code of conduct. I'll be reflecting on practice as a chief executive who is a nurse. And most of the executive directors will be doing that because most of them are professionals as well. But we need to think of those that aren't under a professional body, how we maybe put in place a process in the meantime, and then feed in our experience into the national conversation.
Exactly. I think you're right. There's one thing we can influence, but there's things that are in our gift now. So it's making sure that we do that. If people are okay, I'm going to stop there and let the chief executive have the last word for today. This is clearly a subject that we will need to come back to quite quickly. So I'm going to move us on for today, but it doesn't mean that that's the end of the conversation. If anything, it's the beginning of the conversation, if people are all right with that. So I'm going to move us on now from the chief executive's report, and I think we know we cannot but notice how hot it is, but support you in terms of trying to put as much planning in place, both to deal with the current level of hotness and the anticipated levels of hotness that may be coming towards us as we come towards the year end. Thank you for that. Can I now move us towards this month's strategic review of one of our breakthrough objectives? The one we've chosen for today is this: how we strengthen the way we support people at home and in the community. And I understand in the circumstances, I'm looking to John Child and Colin Hicks. This is a fast-moving environment. Looking to John Child and Colin Hicks to take us into this.
Thank you, Chair. So I'm going to start and then do with John through the slides. So hopefully everyone can see the slides that are now being projected. So this is a review of the prevention slide, which is about strengthening the way we support people at home and in the community. Next slide, please. So just in terms of kind of sort of presenting to the board, people will remember that we agreed 3 specific outcomes underneath the prevention umbrella. One was focused specifically around our vacancy rates, which we know are particularly challenging within our kind of urgent care services. There's a further one which was around reducing the need for hospital admission through strengthening our kind of crisis and community provision. And the third was specifically focused around the provision of inpatient care, and actually how do we try to ensure that we're delivering high quality care within an SPFT provided bed, as opposed to utilising out of area placement and independent sector beds, obviously with the exception of specialist in-placement services that we currently don't provide. We'll cover each of those 3 areas in a little bit more detail over the next 3 slides. You'll see just in terms of this summary slide that except for the first one, which I'll talk about shortly in terms of the particular challenges we've got around our vacancy rates with our urgent care services, the other actions that we assigned are either completed or they're on track for completion. So we're making good progress in this area, although John will add some kind of caution when we get to that point. Next slide, please. John.
Thank you, Colin. Chair, as you know, Fumi was going to do one slide and Peter another, but I will cover them all due to conflicting arrangements and sickness. So the first slide here that you can see is building on what Colin was described as seeking to provide alternatives for patients to come into hospital. And you can see that the graph on the left-hand slide describes a reducing number of patients being assessed as needing hospital admission and us being able to successfully provide them care in the community. I just think it is worth pointing out that that does take into account our reducing number of independent sector beds as well. So it's not simply because we have a reducing bed stock, it is also actually because we have worked to support an increasing number of patients in the community. The narrative in the slide just describes some of the highlights of the work that we've been doing, and I'll just draw out some of those threads. So the emotional wellbeing service you've heard us describe before as part of our ongoing transformation of our community services. This is very much the primary care focused service working in the clinical area between primary care and the secondary mental health care service, closely embedded within our primary care networks. We've been seeking to change the skill mix of our community mental health teams, recognising both what our patients need and want, and also our workforce challenges. And as you can see here, we've described our housing workers and our dual diagnosis workers, both of which have been successful. As part of the urgent care plan, we have set up a dedicated blue light line. This is really so Sussex Police, South East Ambulance Service can get access to clinical advice, clinical support and guidance very swiftly through a single point of access. In terms of just supporting people to have different alternatives into crisis care, as the board is aware, we're doing a particular piece of work with the Staying Well crisis cafes, where we're just looking to expand the offer for them to become accessible, walk-in and self-referral. And in West Sussex, imminently, we will be opening in partnership with the community and voluntary sector, a further recovery house or a crisis house, as colleagues may better know it. You go to the next slide, please. Thank you very much. This is picking up the work that Colin has just described around seeking to reduce our vacancy rates within our urgent care services. As you can see, that is an area that we continue to experience challenged. As part of the urgent and emergency care improvement plan, we do have some ambitious plans to remodel the urgent care pathway, really looking at the function of our crisis teams to ascertain whether we have the correct balance of assessment and treatment, to check to see whether, in the light of right care, right person, is our street triage model still fit for purpose? Are we getting the best outcomes for our patients as to having working as closely with Sussex Police in that model of care as we are, now that we have developed crisis cafes, staying well cafes, recovery services, and that we have 5 havens up and running. So it's a time for us to think about our crisis model. In terms of enhancements, recruitment enhancements, colleagues can see here, we have recently launched, we agreed as an executive, a number of recruitment incentives which are focused specifically in West Sussex, both adults and CAM services, because that is where we have our highest level of agency staffing and some of our highest level of vacancies. Could you go to the next slide, please? Thank you very much. This is really sort of following on from the first slide, and it describes our reduction in use of independent sector bed provision. And as you can see from the graph, our independent sector bed provision peaked at about 100 this time last year, and in line with our plan throughout this year, both our quality plan and our financial recovery plan, we have sought to reduce those, and we're currently operating with 40 beds outside of the trust, the lowest for 18 months. But I think it is important to stress, as Jane has said throughout her conversation, the system remains very hot. There does remain a considerable level of demand, a considerable level of clinical risk, and that is supported and accommodated by us, but also our other social care and NHS colleagues. So it is not without its own challenges. And that is also, and I will talk about this more, I'm sure, when we get to the integrated performance report, compounded by the number of patients with us who could be supported to receive their care elsewhere. Again, just a couple of highlights of the work that is underway. Our reducing length of stay program continues, which has been, as you know, a sort of a year-long quality improvement initiative focused work across our urgent and acute inpatient pathways. As I mentioned at the beginning, when we were listening to the patient's story, we are undergoing a review of our havens to ensure that our clinical model is as effective as possible and we're getting the best outcomes for our patients. We continue to use our bed resources flexibly, and by way of example, have been doing so all this week with using our dementia beds flexibly, our rehab beds flexibly, to support our system partners as they are having to respond to ongoing industrial action. And my final point would be, as Jane's described, we have completed our winter plan, submitted that to our system partners and regulators, and we are continuing to do work thinking about what options are available if there were to be non-recurrent funds made available over the next few months. I will pause, Chair, and I'm sure between Colin and I, we're more than happy to take any questions.
Okay, lovely, thank you. If we could take the slides down. Thank you very much. So any thoughts or questions on where we are with this breakthrough objective at this stage in the year? Okay. Joe. Okay. Joe.
Sorry, a bit slow there.
Oh, no.
I'm sorry, I'm trying to sort of frame the question, and I think thank you, John, and thank you, Colin. What I was wondering as I was listening to that and what we're doing was a question running through my head is, how is our membership, or how is being part of NHS Sussex helping us to address some of these issues?
Shall I take that, Chair, if that, John?
Please, yes. As the two of you see fit.
So I think it's absolutely kind of sort of essential to this, because although we're seeing these as our breakthrough objectives, the delivery of them has to be done in partnership with the various kind of sort of different organisations. So you're starting to see a much stronger theme in terms of our collaboration with the kind of sort of the voluntary sector, which is being facilitated by sort of the ICB as well. And, you know, obviously our particular challenges, as we know, are a patient flow, whether that's about...
You've gone mute, Colin.
Can you hear me now?
Yes.
Sorry, I don't know why my mic died. Yeah, no. So I think it's absolutely essential being part of it, because all of the elements of this are sitting in various kind of sort of system programs that we're leading, which have got a full variety of kind of sort of partners kind of contributing to the solutions.
And so, but then how do they, what are they, how are we bringing it together with them and their input?
So we have a number of kind of overall programs of work. So principally the two that we'll talk about here. So we have a mental health UEC program of work, so urgent and emergent. We have a big program of work around adult community services. Both of those have got our exec directors as one of the sort of the SRO roles. And then all of that feeds into and reports up.
I don't know what it is, but every time you start to talk about the added value of the ICS, it goes quiet.
Shall I take over, Chair?
Yes, I think so.
Well,
while Colin sorts himself out.
Chair, if I may, what I was particularly interested in trying to draw out is within NHS Sussex and the response to the medically fit to discharge problem that we have, and the role that both the Trust and those who are responsible for social care are playing and contributing to how we resolve the problem. And it'd be really helpful to understand how the parties are coming together to address that under that umbrella.
Okay, so Jane, I think as the chair of the collaborative, it would be helpful if you could come in as well, and then I'm happy then to go back to John and Colin.
I was actually talking to Becky Shaw, the Chief Executive of two of the local authorities this morning about this. And I think one of the things that we've done historically is think about individual patients and what are we going to do for an individual patient and how we're going to put this bespoke thing around them, which is right in one sense, but it's very short term. And so one of the things that I was saying in my Chief Exec's briefing is that sort of recognition. I think we've brought together a recognition in the system that under the current situation in social care, they cannot make the gains that we need them to make over the next year. That's just not going to happen, and we need to be realistic about that. So if that's the case, what do we do this year together to manage the winter pressures? But then how do we come together with social care and the voluntary sector and our acute and community providers over the next 2 to 3 years, and what do we need to have the headroom to do that over the next 2 to 3 years to do something radically different in the community space together, rather than saying the problem's all with social care, because they have their own pressures, we have our pressures, and we need to see them all as system pressures that we need to find an answer together with. So at the moment we're in the state of accepting the problem, and that actually we need to do something radically different if we're going to get a different outcome, not just keep moaning about it and not just keep saying the agency needs to do something.
Thank you, that's really helpful. Simon.
I was really pleased to see the incentive schemes in the slide 4 around the urgent care. I guess I was interested in the fact that there's very front loaded in the first 2 years, and my understanding around lots of vacancies is that often you can fulfill some of the issues for the first 2 years with these type of incentive schemes, and I wondered what thought we needed to give beyond to keep them beyond those 2 years, given that there are national shortages, that other people will be putting in place incentive schemes, etc. And so that we don't end up with a really good solution for 1 or 2 years and keeping people in, but then just pushing it sort of slightly down the road, so we're not keeping for 3, 4, 5 and beyond.
Yes, the risk is that people go shopping for different incentive schemes. Yeah, John.
Thank you, Chair. Danger of repeating what Jane has said, but to answer Joe's specific question around how will we sort of get support and how colleagues, system partners coming around this. The National Discharge Front Runner Programme, with which Sussex is one of the vanguards. We have chosen in Sussex to develop a specific mental health discharge stream as a result of that, in effect, in a result of the pressures and the challenges that we've articulated. We have persuaded one of our executive directors of adult social care and health to chair that, which really sets a benchmark for the system in terms of the level of involvement that they have in it. And so far, we've had 2 meetings that has been galvanizing, and I've seen greater level of housing input in those conversations than I have in many of the other fora over the years. I don't want to overplay that. It remains a very significant challenge for us. The models of care and accommodation to support our patients easily don't exist, but it does feel like that is becoming more recognised in terms of the challenge. To Simon's question, Simon, I'm surely not going to do the justice that Fumi would, so other colleagues may wish to come in too, but I will try. I think you're absolutely right. Our first initiative is to fill those vacancies and to get more staff in, hence the fact that we have deliberately front-loaded them, not least because one of the challenges that we hear from many of our colleagues and many of our staff is simply there are not enough of us, and there are not enough of us of the right quality to enable the work and the workplace to be sustainable. And if we can manage to fill those vacancies, then things become more palatable for colleagues, and by default, the well-being and pressures become less. However, we do need to consider our well-being offer, our continuing professional development offer, and let's not be shy, there is scope for ongoing retention incentives, not just recruitment ones, and we have an internal process of how to do that. And some of those are financially incentives, as well as other things that might be slightly more innovative.
Thank you.
So is that something we now have enough evidence around to be able to plot trajectories, or is that something experimental that we're trying out and we don't quite know what impact that will have?
Shall I speak to that?
Yes.
So if I start off by saying the reason we did it for the first 2 years is because based on our data said that the majority of people left within the first 2 years, and if they stayed longer than 2 years, they tended to stay with us. So that's why we targeted that end in the first place. But there's another piece of work in that this is a pilot, and therefore we're measuring it, and we're measuring the impact of it. And then we might expand it. We might then adapt it to something different, but this is very much set up as this is a pilot. And also it is, if another area feels that the incentives could work for them and we can measure it, then they can apply for it. And that might be if for 3 years or whatever it is, that we've got a mechanism in place that there's local ownership of their local problems, but that we're measuring against it. But absolutely, we started this because that's what the data indicated we needed to do.
Does that help, Simon? Yeah. Okay. Thank you.
Yeah, absolutely. I guess just it was interest, about what happens beyond the 2 years. So it'd be really exciting to see what happens, because it's obviously a really important area, for the short and medium and long term.
Thank you, Dan.
The only point I wanted to underline on that, which I know is in the People and Culture Plan, which for me is finalising as CPO, is about us thinking beyond recruitment to traditional roles and thinking very creatively about new roles, which is an issue we've discussed as a board previously, with reference by way of example to the voluntary sector compact that CEO referenced earlier.
Yeah. Any other thoughts or contributions? So as we start to think about next year's breakthrough objectives, where do we go next with this? Is it more of the same? Is there another trajectory now that we want to get on? The work with the local authorities sounds potentially exciting, that we move away from being nostalgic for a past that never existed to being a bit more realistic about the way in which we can work together. Where do we go next with this? Jane.
So So my view is, at the moment, and I've been thinking a lot about this actually, and I think what I was thinking, so what is the next stage? And I think it is, how do we move the breakthrough objectives? We're now at the stage of the year where we need to start thinking about next year's breakthrough objectives. And I think we're also moving into the last year of our current strategy. And I think rather than completely reinventing the wheel and doing something completely new for next year, it's how do we push ourselves to the next level next year within the framework of what we've had this year, so that we're not trying to start from scratch. And then that sets us up for through the co-production of the next 5-year strategy.
That's helpful. Thank you. Jessica, hi.
Hi there. Apologies if this has already been covered before, but I wondered if a mapping exercise had been done really to see exactly why there is such demand. And I mean, we generically talk about crisis, but what are the elements of the crisis? And so as to better understand how we can meet the needs and divert appropriate resources within the constraints of the system.
Yeah, I can see that Colin's very much looking forward to responding to that. Colin.
I was going to come in off the back of Jane, Chair, in terms of your original question. I mean, I think in terms of picking that up, I think one of the things that we're in the process of doing is really trying to get much better data, much better analytic understanding, particularly from a kind of more prospective way, about understanding the need in the kind of the community. What we're seeing quite a lot of was predicted through COVID anyway. So, you know, if you look to the predictive data that we had when we went through the pandemic, we knew that we were going to be having the mental health pandemic equivalent, if you like, at about this time point. So what we're seeing is anticipated. I think what it's challenging us to do, though, is to really sort of stretch and think about some of the areas where some of our more traditional pathways of care don't quite fit the kind of the presentations of the people that are kind of coming through now, and we're having to really kind of rapidly adapt and adjust. We're also in the process of kind of recruiting for us a public health consultant, which I do think will be a real game changer in terms of really understanding some of the kind of some of that kind of granular population level information that then allows us to start to have less of a kind of generic service offer, but really starts targeting segments of our population.
Is that what you had in mind, Jessica?
I mean, basically trying to understand why people are in crisis, rather than just assuming that all crises are the same, or that they're always driven by financial pressures or homeless pressures. Are there resources? Are there ways of working and education needs that could be scaled up to respond? And also, I suppose, thinking about the sort of service that I work in my clinical work, is providing space for talking always necessarily the most effective thing? Do we need more occupational therapists? Do we need more people who can help people regulate themselves in a non-talking based way?
Yeah, thank you. I'll come back to you, Colin, but I'll just run with this and then I'll come back to you. So Teresa and Dinesh. Teresa.
Thank you. So I think really just to Jessica's point, I'm sat thinking, and how do we avoid the crisis? And what does that mean for a breakthrough objective potentially next year? Yeah. So you'll always hear me talking about what is the early intervention and prevention piece, and how might we consider that together through the eyes of breakthrough objectives that don't feel disjointed from this year's breakthrough objectives, but almost what's the next step, and how do we use multi-professional roles and that might not be traditional roles, new roles, to be able to deliver on some of those plans. And I think the timing of that into next year is perfect, actually, because we've got all of the work around the community mental health framework. So for me, I'm sat here thinking, how do we take this year's breakthrough objectives, iterate them smoothly into objectives next year that fit the context of what our priorities are going to be next year, not least the community mental health framework, and frame them in a way that allows us and almost forces us to be thinking, what is the early intervention and prevention piece at a time where the system is hot, because when the system is hot, our eyes divert to the acute end of the system. So I'd like us to have a set of breakthrough objectives that force us to be thinking upstream.
Yeah, thank you. Dinesh.
I think the idea of having a public health physician is an absolutely superb one. And I think one of the big challenges in, going through the conversations about the NHS, one of the major things that emerged was creation of health. Because by the time people get to the hospitals, it's far too late. And hospitals are also much more expensive than primary care. So we need to kind of go back and look at the beginning when people are beginning to feel unwell, and how can we support that? One could argue that that has nothing to do with the hospital or the trust, but I would disagree that if we actually go out and do something outside the box, something innovative, it would A, raise the profile, B, provide better care for patients, and C, improve the staff morale. So I think we need to sort of link all those together and be out there rather than just focusing on waiting for people to come to us.
Yeah, thanks, Dinesh. I'm still working my way back to you, Colin. Kevin.
Yes, I don't want to go against what my colleagues have said, but there is an extreme end of that, isn't there? Where I think we also need to be mindful of what we do and what we do in partnership, and also what other resources are out there, and particularly what's the system's response to prevention and to getting upstream. We could absolutely be kind of innovative ideas, but we also need to remember what it is we do, if you like. So it's a balance, I think, with the whole system in getting there, and providing our expertise actually to the system in prevention agenda, I think. And in terms of breakthrough objectives, Peter, I think that was the original question, wasn't it? Where are we going to move to? I would be really happy if as the place-based arrangements bed in, if there was something about how those relationships, and that's the word I think, are bearing fruit, and how we're learning about strategy from the frontline upwards. Actually, there's something about that, something about whether it's the QI process, but specifically about what we're learning about the places as we become more place-based.
Thank you, Kevin. Really helpful. So, Colin and John, you've heard some. Obviously, you've responded to some questions, and you've heard some thoughts. Is there anything else you wanted to add today, or to respond to in terms of next steps that we could pick up?
No, I think the only thing other that I was going to add in, Chair, just in terms of thinking about the kind of the breakthrough objectives, is just recognising or just reminding the board that when we set the breakthrough objectives for this year, we talked about having short, medium and long-term horizons. Yeah. And whilst I think we're making good progress in the majority of areas in terms of how we articulated the in-year position, what I wouldn't want us to do is lose sight of the fact that we also set medium and longer term horizons to those, which then stretch into the sort of subsequent kind of sort of financial year. So I think for me, probably echoing the point Jane made, I think there's something about doing a stock take around where we're at, understanding what our intention was in terms of those medium and long term, but obviously adjusting and amending them based on the kind of the current climate that we're kind of sort of finding sure. sort of ourselves in.
Yeah. And my sense is that the board is supportive of that, that we want to see, we recognize that this remains important, and we need to get them on the right trajectory, but we're just looking at, well, which things can we deprioritize and which things can we add? But my sense is that workforce recruitment and particularly retention is going to stay an issue, but we do want to look at new roles, and we want to continue to bring voluntary sector colleagues into that multidisciplinary provision. Hopefully, either through this breakthrough objective or through one of the other breakthrough objectives, we can think about, well, actually, how do we get upstream in terms of understanding what the drivers of crisis are and what the cofactors are in crisis, and that may be with its system partners or within our collaborative partners, and that there is something very exciting potentially about the fact that we can keep reframing what integration means, both in terms of the specifics of provision, but also the relationships, and that the relationships may then help us to shift some of those wicked issues. But I think the board is very supportive of the fact that we need to continue with this theme and to recognise those medium and long-term objectives that we set. But I think what we've done today is just think around some of those a bit, which hopefully then can be taken into account as we recraft it. Is that an okay place to leave it today? Thank you very much. I thought that went really well, the way that was presented. I thought that was very clear and very helpful, the way that was presented. So thank you very much for that. Can I now move to the Quality Committee report? And I think what we've agreed is that Teresa is going to lead on the Quality Committee report, and then obviously Dinesh and Kevin can contribute as feels appropriate. Teresa.
Thanks ever so much, Peter. So yes, ordinarily Anna would present at this point, but I'll cover this for her today. So what I'm about to describe is Anna's reflections as much as they are mine. We had our last Quality Committee meeting on the 29th of August. We began with reflections on the Lucy Letby case and reiterated our commitment to learning lessons from these shocking events and the failures in organisational culture that came to light. The committee discussed the need to think carefully about our processes, our relationships, to be data-driven and constantly alert to our colleagues. As Jane had said earlier, strengthening our freedom to speak up activities and really open reporting and pushing forward with the new PSERF that I know we've spent quite some time together talking about in recent months. The committee received comprehensive reports and assurance on safeguarding, influenza, health and safety, provider collaborative updates and reports from the Quality and Risk Management Committee. So these are the subcommittees to QC and the People and Culture Committee, as well as a detailed update on Chalk Hill. And we were given assurance that the oversight of our external contractors had been strengthened as a result of the board's request from last board meeting, the details of which are in the paper. So Peter, I'll pause there and take any questions.
Okay, thank you. Are there any questions on the Quality Committee report or comments on the Quality Committee report? No? Okay. What's most worrying us at the moment, Teresa?
What's most worrying us? What a good question. I won't say it's what's most worrying, but one of the things that comes to my mind as you ask that question, Peter, is how free do our colleagues, and I think it goes back to something that Jane said earlier around the silent majority, how are we enabling and reaching out and embracing those conversations with colleagues? So I can think of a couple of occasions recently where people that we might not have heard from before have very courageously come forward and had conversations, either by direct email to Jane as Chief Executive or corridor conversations. And as an executive team, and I'll speak for myself in this, but I know that this is no different for any of us on the executive team. It's about reaching out and absolutely having those conversations, truly listening to staff, but then acting on what it is that staff are telling us. So if there's one thing that concerns me, it's about people feeling safe to do that. And then when people do feel safe to do that, our ability to respond and act. Yes. And that then is reinforcing the organisational culture around true openness and being safe in being open.
Yes, yeah, I've been in lots of meetings recently where people have talked about listening, and unfortunately there is a sort of line that comes into your head that, well, listening's one thing, acting is the next thing. Acting's the next bit. Yeah. Okay, thank you. Dan.
Yes, and I'd add to that, and it very much chimes with the discussions we've been having in the most recent round of quality and performance reviews, where we were looking, for example, at our continued low response rate in the Sussex Experience Survey, which is our equivalent of the Friends and Family Test, which has led us into a conversation both at QPR but also as an executive team about how we systematically collect and act upon and co-produce improvements in response to feedback that comes from individual patients under the care of our services, looking above and beyond those existing formal mechanisms that exist, including the annual Community Mental Health Survey.
Yeah, thank you. Yeah. Joe.
Thank you. So 2 points. One, just in relation to Dan's point. Dan, in fact, I'd made a note in having picked up on the improvements in our handling of our response to complaints, whether we could have some sort of follow-up in terms of the feedback from complainants in terms of their experience and how they feel we're doing, and not just what we say about how we're doing. So, and I think it's really great that we're doing so much better after 24 months. So if there's a chance to pick up on that. And then the other, Teresa, going back to the quality report, particularly I wanted to pick up on the annual safeguarding report. Towards the end of that, in the conclusions at 8, a statement is made that there's an ongoing issue with non-compliance with named doctor for safeguarding children, looked after children and children in care. Now, I know that it's not a problem that's a particular challenge just for this trust, because I know it's a major problem for a number of the major children's charities. But what's the particular issue and risk for us in terms of that remaining unfilled as a position?
Thanks, Jo. So it's being covered currently, and it has been an issue for some time, as I know it is nationally. But there is a conversation booked in with me and Peter Aitken, with our lead for safeguarding, to explore what else we can do. So very happy to pick that up and then feed back to board on the actions that we'll be taking.
Yeah. Just a supplementary then, are there any immediate risk? Are we exposed in terms of any current issues?
No, there aren't immediate risks. But it's not an ideal situation. And Peter and I recognise that, so hence coming together with Phil Blurton to explore that further.
Thank you.
Okay, thank you. Dan, can I just ask you, in terms of, we do get an annual complaints report, which tells us what the themes are from complaints. Is it possible to get something a bit more about the experience of being a complainant and how happy people were with the outcome of the exercise? Is that relatively easy to do?
I think it's the vital next phase of our improvement work in relation to the complaints process. So it's about making better use of the complaints data we have and really understanding the themes and getting into more granular detail, triangulating that complaints experience data with other sources, but also drawing upon qualitative experience of our complaints process. And without going into detail, I can think of a live example where we've got to the point of having a conversation with a complainant that, in their own words, has started to make them feel heard in a way that our formal written responses weren't achieving.
Yeah, good. Thank you very much. Simon.
I was really pleased to see that there was a detailed report about people and workforce. And I think at the Strategic Development Day, we had a conversation, which was, how much of the national context do we need to recognise it? I guess when you said, what are we most worried about? If I was to think about the NHS as a whole, and then my question is related to the trust specifically, but I think it has to be workforce in terms of both vacancies that are being held within the NHS, but also the well-being, motivation of staff. And I thought it was interesting that was reflected in the paragraph on staff and their experience, because I think we can put in place all sorts of systems and processes, but if workforce, if the workforce isn't there supported, then it will always be an inherent risk. So I guess I just wanted to acknowledge that, but in the wider context of the NHS, but also just ask, what is my question? I guess just to acknowledge it, I guess that the workforce and the workforce issues are perhaps one of the things which I'm most worried about, both here, but more broadly across the NHS.
Yeah. And I think Simon, that for me, I know has been talking with Jane and the team about the fact that we have some fairly, it's not meant to sound critical, but it's from fairly standardized ways of reporting on workforce. And we have some very familiar metrics that we report on, and they're important. But actually, if we're going to really get into culture, and we're going to really get into quality improvement, and we're really going to get into organizational development, we need to rethink how we capture this, which I think we probably do capture in different across the organization, but we don't necessarily see that reflected currently in the way we're reporting. And I think that's something, without creating an industry, we do want to look at. And I think that may be behind what you're saying.
Yeah, I think so. I guess it's also just all of the good things that we put in place will always have limited impact when staff are struggling just to make things work. I think that's the bit which actually is probably just to ignore. So QI, development, etc., will always a really important thing. There's great conversations in relation to that, but when there are high vacancy rates, we just have to be conscious of what we're expecting from people, how far they can go, and the impact of that on their ability at work. So that's where I was heading, I think.
And some of that should come through the pulse reports around the staff survey, but that's again is something we can look at in terms of what is it we're trying to capture. Kevin.
So there's, I guess what I'm also hearing is there's a particular challenge, and in the positive sense of the word, back to the QC about how we look at that and how we look at people and culture in particular. I'm also mindful that there's a new people and culture exec committee, and in other trusts there's a people and culture actual committee of the main board. So there's something about how is that reflected, how is that synthesized, and are we the right conduit for it? I think checking with that afterwards, but some thinking to be done on that, I think.
I think that's what for me is and Teresa and others are discussing, because what we don't want to is overload one committee, but we don't necessarily want to set up lots of committees. So we just need to work out what's the best way of the right information flowing where. Do you want to come in, Teresa, or are you happy to leave it as something we're talking about?
No, I'm happy to just continue to take that forward, but I think the conversation in the last few minutes also for me goes to the heart of retention. So the link between QI and retention, being able to implement your own change ideas and then take control of the services that you're delivering, you're more likely to stay. So recognizing that sometimes there's not even a thread between these agendas, and one is supporting the other.
Yeah, brilliant, thank you. Is there anything else on, I know I've got to come to the specific reports in a minute, but is there anything else on the quality committee?
No, not specifically, thank you.
Not specifically. Okay, so we need to note the report from the quality committee. We need to receive the safeguarding annual report, receive the addendum to the health and safety annual report, and to receive the seasonal influenza campaign report. Are people happy to do that? They're received. Thank you very much indeed. And on the basis of a very small sample, we have to question whether you should have the flu jab and the COVID jab on the same day. But,
I can tell you it's fine. We've all had ours today in the executive team.
How many people have gone home sick today?
Nobody, Peter.
Well swatted, Chief Nurse. Well swatted. Thank you. All right. Can I now move us to the workforce report, and particularly the RES-W DES? And Dan, I think you're helping us with this afternoon.
I am. Thank you, Chair.
Thank you.
So you have two formal reports which we're required to bring to the board formally: Workforce Race Equality Standard and the Workforce Disability Equality Standards. You'll note from the report that there has been an improvement in performance against 5 of the 9 RES indicators, and the Trust has maintained or improved performance against 7 out of the 10 workforce disability metrics. That said, if Fumi was here as CPO, she would be saying that these metrics do provide us with one measure of performance. And whilst it's encouraging to note improvements, it's clear we have a lot of work to do as a service provider and as an employer to systematically challenge discrimination and marginalisation in all its forms, and to promote inclusion rather. And I think it's timely during Freedom to Speak Up month to be continuing to think and take action about how we make sure and what more we can do to ensure that individuals themselves can raise concerns without fear of silence, sanction or inaction, which goes back to the point from the chair's report earlier about creating a culture of curiosity, and the discussion point in the CEO report about a culture of genuine engagement that in turn leads to action. So I think they're important points of framing to mention and bear in mind as we formally consider the reports. All of that said, I'll take the reports as read, and I'm sure my exec colleagues will support me in addressing any questions or issues which emerge.
And just while people are gathering themselves down, I still have John Amici's phrase in my head that we in the NHS we are in danger of weaponizing a lack of curiosity. And I think that need for constant encouragement of curiosity is incredibly important. Thank you very much for stepping in to do that. That was really helpful. Jane.
Thank you. I suppose I want to very publicly say it is great that we've made improvements, but as Dan said, it's not good enough. No. It's not good enough that Black and minority ethnic groups within SPFT have a different experience than the white population. And I know we all know that, but I think it's important to explicitly say it. And one of the things that FUNMI is currently doing is rethinking our approach to equality, diversity and inclusion. And she'll be coming to Equality Committee with a really robust plan that is about cultural change and real system change, not just initiatives to tweak the statistics that are showing that things aren't good enough. I don't want to move the statistics if it doesn't mean real culture change. I want real culture change that is indicated through the statistics. So I just felt like I wanted to say that in the board.
Yeah, and I think it's important to acknowledge the improvement, but on the other hand, you know, a third of staff experiencing harassment, half of staff believing that we don't have just processes and procedures. I mean, these remain very, very worrying and troubling figures. So even though there are small improvements, you're absolutely right. Osman.
Thanks, Peter. I guess I will make a personal confession and say I personally sometimes struggle to talk about the res, because it can sometimes, to me anyway, it feels like me talking about it makes it tokenistic. So I struggle with this a little bit. And I think it is worth recognizing that we have made improvements. And I guess Jane's already said it, but it's one of the things that we've discussed and I've discussed with her, but actually we've also deteriorated in a number of areas, and deteriorated significantly. And I think we should be open about that, and we should call that out. And I think that's not just about doing the right thing, but with my ever practical hat on, we constantly talk about our workforce challenges and about how we don't have enough staff. And actually 14% of our staff are from an ethnic minority group, which is good that we're up from last year, but actually low compared to the Southeast and national. And so fixing some of those, you know, I think it's fair to say are relatively deep-seated challenges actually is not just the right thing to do for the people who currently work here, but it will make us a more attractive employer for a wider range of people and address some of our other challenges. And so I think it is, and I FUNMI takes it, or all of us take it seriously. And I think it's interesting that we operate from one of the most diverse boards I've ever worked on, and the most diverse exec team of one of the most exec teams we've worked on. And I think it's on us to help make sure that we do prioritize this and not just, I think, congratulate ourselves a little bit too much at times, which, and I'm not saying we do, but again, as you can tell, I find it slightly uncomfortable talking about this. So I'll bring myself to the end there.
Thank you. Dinesh.
Thanks very much, Peter. Just building on what Usman said, I think I'm happy to volunteer to do some cultural competence training And I have colleagues who will be very happy to come and talk to the trust about working with interpreters, etc. So, feel free to abuse me.
I'm sure we will. Thank you. Rachel. We can't hear you.
She's just coming off mute, Chair. She's just struggling with her mouse.
Sorry, I have 3 screens and I'm trying to find my mouse. I'm chasing it around the screens. I was just going to comment with regards to the action plan associated with this and to challenge our thinking when we're setting some of the objectives with regards to what good looks like. So I think to refine some of them rather than launching networks or procuring items, to look specifically with regards to the impact of the outcome rather than the process itself. So we can launch networks, but we need to measure the success of the networks. And I just would like us to be challenging ourselves with regards to refining those objectives, making sure that they're smart, looking at the impact and the outcome as opposed to the process itself.
I think that's a very fair comment. Dan.
Yes, following on from that, and I should have mentioned this earlier, the Equality, Diversity and Inclusion plan that Jane mentioned, to my mind, has really benefited from Fumi's experience and expertise in getting us to be very clear, very focused and very concise, both about the actions we will take in the next 18 months, but also those outcomes we are looking to achieve. And because it looks through the issue from both a workforce lens and a service user lens, our plan is to bring that both to Quality Committee and to People and Culture Committee.
Okay, thank you. Kevin.
I was thinking about this from a kind of a what I really liked was the night waking example within the report of something which is targeted, specific, looks at things through a global majority viewpoint, and then tries to do something about particular experiences. And I was wondering, if that is more generalized, i.e., do we know the various data points which relate to real human beings, which areas, which services and which parts of the trust do we have more of an issue with, if you like, and should we be differentiating and targeting resources like that? I guess that's my question.
I lost your question, Kevin. Help me.
Okay. So I was picking the night waking example. It was a really good example of picking a particular area where we've identified that we have specific challenges. I was wondering if we were using the data points and the triangulation of those data points to pick particular services, teams, and areas where we think we have specific issues, and if we were therefore targeting our change initiatives on those areas. Is that a very long question?
Yeah, that thank you. It was my. I just lost it. So thank you for bearing with me.
Thank you for finding it,
Jane.
So the short answer is yes. I would say not so much around service areas though, more around things like banding or professional group. So we cut it in lots of different ways to look at. So the nurses at lower bands and healthcare assistants at lower bands are more likely to be disciplined. At the other end, medics are more likely to be of a BACA minority ethnic group, and so it's looking at different groups. So there are different things in different areas. So we are cutting it in lots of different ways. So I think it's that I can't really mention it earlier. It's about having that curiosity about data and not just cutting it one way. And one of the things Usman and I have been talking about is how we cut the data around race and disability for our quality performance review meetings, and how we get that in so that we're talking about it with leadership teams. Yes. and fostering that curiosity.
Yeah. So I've got Usman's particular comments ringing in my ears, and I don't think that we should, any of us, should feel that we're in a position where we feel uncomfortable about drawing attention to this. I want this to feel like it's a conversation that's very normal for us to have. I've talked to the Chief People Officer about how we bring this to board in a way that, yes, looks at workforce, but also looks at the wider organisation, and how we can actually have a more determinedly anti-racist approach across the organisation, and then to look also at other data points where other protected characteristics may also be relevant. And I know that is something that she is working with you and the executive team on, Jane, and then we will make the board time available to think about, well, how do we make sure that we're doing this right the way across the organization, that we're cutting the data in the right way, we're getting the granularity so that this becomes part of our day-to-day business, and we're not having a conversation about whether we've gone from 1.52 to 1.64. We're actually feeling like we're on a trajectory and that we're tackling those issues. My fear, Usman, is always that I end up virtue signaling, and that's my fear. I would in some of these conversations, but it does feel this week already we've seen weaponizing of different identities, and I think we need to make sure that this organisation is challenging that in a meaningful way for our patients and our staff. Is there anything else on the res and the WDES for today, Dan?
No, just to note the reports formally.
Okay, thank you. It's, well, sorry, not telling you something you can't work out. It's 3 o'clock, I was about to say, as if I was telling you something. It's 3 o'clock. We've got a little bit of time. Would people like a 5-minute break? And then we'll come back and do the staff experience if we could make it about 5 minutes, please, just so that we don't lose energy and we don't lose focus. Would that be all right? But people might just appreciate a chance to stand up, move around, feed their addictions, or whatever else they need to do. We'll use the same link and we'll see you in 5 minutes. Thank
7,
you.
Chair, then 3:07.
Thank you. So in terms of the staff experience quarterly survey, I mean, clearly in some ways we've been discussing this as we've gone through the meeting, which is absolutely what we should have been doing. But is there anything specific we wanted to pull out of the data and the survey? Jane.
Hi, so it's not specific about the data and the survey, but just to follow up on what the thing that we've been talking about is how we adapt our pulse surveys so that we can get a regular sense check across the organisation rather than waiting for one-off audits like this or one-off staff surveys, and how we integrate the learning from this and what comes out of the staff survey into our regular pulse surveys.
Yeah. And can I just, I suspect the answer to this question will be yes, but can I just check that we're then disaggregating that data by at least the four main protected characteristics so that we can actually check?
We will be, yes.
Thank you. Dan.
I was going to say work in progress, an example which we've discussed on a number of fronts previously about how we could improve that triangulation of data from different points. To my mind, this does feed back to the conversation we were having earlier about organizational development and making sure that it's organizational development with a purpose that draws on the learning from staff experience. And it's an issue in my mind because I spent a couple of hours with one of our teams very recently where it was clear that the reflective practice sessions they hold have become embedded within the way they work with each other day to day and the way they engage with each other. So it's just a kind of a live thought that's in my mind in looking at this experience data.
Thank you. That's helpful. Joe.
Thank you. Dan, I know we didn't plan this, but what you just said about reflective practice, I thought that my first point in relation to this was that there are going to emerge some interesting points and insights in terms of behaviours and approaches within our staff, and it'd be very helpful to see a year's overview with a breakdown in terms of the particular trends and identifying the particular priorities and what needs to be followed through. But in terms of reflective practice, if we were joining the dots and looking at supervision, appraisal, effective feedback, and then looking at the leadership programme, I think it makes it a much more real and meaningful and impactful programme if actually a major part of the content is actually saying to our managers, this is what our staff say, this is what they experience, and you use that as part of the learning. And the more we can do of that, and to do it in a way which is not just about rear mirror driving, but forward focus, and see how that then follows through. And I've seen that work really well. The other thing with this was that personal plea, please. I still found the typeface really quite difficult to read. It's quite small, and even if I magnified it, I was struggling. So, and I'm wearing glasses. Thanks.
Thank you. Is there anything else on the staff experience survey? So I think we note that, I mean, quite rightly, we've been talking about staff experience through the meeting. I think we note the fact that we will be looking at a more consistent approach to using the pulse reports, and that we will be looking at the more granular data in terms of protected characteristics so that we understand the variations. We would quite like to look at a year at a time to make sure that we're spotting trends, and recognize that then needs to feed through to, you know, how does it relate to reflective practice? How does it relate to some of the other mechanisms that we're trying to embed across the trust, so that we start not just to have a golden thread, but a kind of golden matrix of different things that are connecting together, which I thought I'd mime at that point, just in case it wasn't clear from the words I was using. My apologies for that. Thank you very much, everyone. Can we now move to the integrated performance report, please?
Thanks, Chair. As we normally do, John and I will do a little bit of a double act. I'll start off and just give a bit of an overview and point out some key areas to note, and then John will come in on any particular areas that he wants to highlight, and then we'll take questions together. So the IPR that's attached goes through the core metrics, which are 12 priority metrics that have been selected to align to the Trust strategic priorities for the year. I think it is worth noting that while those were the ones that were picked for this year, they're not necessarily the ones that we would always have. We will continue to always monitor those metrics, but it may well be that as part of the planning round for next year, we determine that some of those 12 need to change. So I think it's just important to highlight they're not necessarily fixed in stone as the core metrics forever and ever, but they were the ones that aligned for this year and will continue to iterate and develop. And I mentioned that because we've had internal sort of exec conversations around actually, as we develop next year's plan, how do we ensure that our KPIs are aligned and that we're really therefore focusing across sort of all of the disciplines into the right areas. So you look in terms of the August 23 year-to-date position, I think it's fair to say that of the 11 core metrics, or the core metrics that we look at for the Trust, we have made progress against a number of them, which I'll discuss in a second, but we continue to be challenged in a number of areas. So activity across the Trust remains at a relatively high level. I think sort of as Colin, John and others talked about through the strategic breakthrough objectives, we operate in a challenged environment at present, and combined with our workforce shortages means that our performance continues to be challenged as well. In particular, I think we've recognized that the number of patients waiting for an inpatient bed, while down from its peak in July, continues to remain high and has been on a sustained position for a period of time now. And a lot of the improvement work that John alluded to and talked about through the strategic objectives are what we are doing around some of those actions to design to help alleviate that situation. And I think it's important to note that when we've done the analysis on that, it's not a case of, while the number of people waiting, the days waiting is going up, it is the number of patients actually requiring admission is not increasing, except that those people who require admission are waiting longer. And that's the sort of real focus of where we're trying to get our effort. I think it links to a number of our breakthrough objectives in terms of improving and enhancing our ability within the communities, also working with partners around our delayed discharge position. In terms of risk assessments and care plans, those are local targets, but really important local targets. We know the importance of making sure that all our patients have up-to-date care plans, up-to-date risk assessments. And we have developed, I should say, recovery plans for all divisions, because it's clear from the metrics, and you can see in the report that we are not achieving that at any of our divisional level positions. Those recovery plans have been developed. We're currently working through them through a number of workshops through October to get assurance and to provide support to ensure that I guess there's something about how do we sustainably actually deliver this. We've been talking about this for a while, and there are months where we improve and then we drop again. And I think there is something about how do we sustainably deliver this. And given that we haven't delivered either of these targets for a period of time. However, what I will say is I think it's important to see those in the context of some really deep-seated challenges amongst our workforce, because in effect, activity has gone up 15, 16%, but the number of lead practitioners who are primarily responsible for this has actually fallen over that period of time. And therefore, it's not a case of people not doing them or not wanting to do them. There is a genuine capacity issue around this. And we have to think creatively about all of the solutions, whether it's technology, whether it's about how we think about giving staff dedicated time to recognize that this needs to happen. So there has been a lot of work. We've just had the September set off divisional quarterly quality and performance reviews, where this has been a particular area of focus. And I think it is fair to say that all our divisions understand where they are, understand what is driving that position, and therefore what they need to do to try and improve it. But I think it is worth recognizing that in both of those cases, it's likely to be a long journey before we get to the targets that we want to achieve, given the workforce challenges that we have currently got. Which neatly leads me on to a couple of the other things I just wanted to highlight. The staff turnover rate, and I almost want to whisper this because it has been a perennial issue for us. We have talked at length about the challenges we face in terms of our workforce and the actions that we are taking against that. But for the second month in a row, we are continuing to see, or third month in a row, continuing to see our turnover rate drop, which is a good thing. And it is now dropping to the sort of below the long-term average it has remained for over a period or over 12 months now. So I think that gives some data-driven evidence of the actions that we are taking to try and improve that position. Clearly, there is still quite a long way to go, and our vacancy rates still remain high. But I think it is a combination of all of these actions that we're taking to try and improve it that will hopefully get us to both a more sustainable position in terms of workforce numbers, but then have associated benefits in terms of many of the other core metrics that we look at. And again, in the same whispered breath, I will say that for the second month in a row, our agency spend as a percentage of our total pay bill, which is another core metric that we look at, which is tied to our strategic breakthrough objectives in terms of the workforce improvements that we need to make, has also been reducing, which is again a good thing. We remain significantly away from the sort of national target of 3.7%, but it is beginning to feel like we are sort of making some improvements. I think it's worth highlighting that we have also launched only in the last few weeks a significant range of new staff incentives to encourage more staff to join us, hopefully reduces pressure on our existing permanent staff, and therefore reduces one of the key drivers for leaving, because we know that the single biggest reason people are leaving us at the moment is based on the exit interviews and what we see through the surveys is around sort of stress and feeling burnt out, and partly that's exacerbated by not having enough people. So it's hopefully a virtuous circle. Clearly, our staff supervision numbers in that sort of same area, we don't want to talk about just all the positives. I think it's worth saying the latest month's figure that's in there, as is the case every month, is always time lagged, because in effect people will do the supervisions, but the recording of them happens outside of that month. But even if you go back and look at the last 2 months of data, we know it has dropped. And again, it was one of the key areas through the divisional quarterly quality performance review meetings that we've carried out in terms of what specific actions do we need to do to improve that. I think it is worth, it's not a secret, it's worth highlighting on page 8 of the pack that is there, sorry, page 9 even, that there is significant work to do amongst the corporate teams as well. We do remain a significant outlier compared to the divisional teams, and I think that is something we have discussed at length internally around how do we make sure that corporate performance in that area improves significantly over a short period of time, because that will support the overall trust position, given that we are quite a significant outlier in that. Finally, just a couple of other highlights, and then I'll sort of go to John. In some positive news, I think it's worth highlighting that on page 13, we talk about the Sussex CYP ED, eating disorders urgent standard. Many of you will know, who were here last year, how challenged that position was. And I think it is a real significant improvement that for 4 months in a row now, we've sustained 100% on that position. And a lot of work has gone in from the teams, a lot of work has gone in by John and his teams in terms of supporting that division to be able to get there. Clearly, the position in Hampshire remains a bit more challenged because of the specific ARFID issues. But again, if you take that backlog and those ARFID patients out, they are also achieving that core standard. It's not that we're going to be complacent about that. We continue to monitor it and take it seriously, but I think it does demonstrate that we can achieve standards even where they seem intractably difficult to deliver. And then I guess it would be difficult for me not to mention that for the first time in 2 years, we have achieved our complaints response rate within 35 days. And again, if we go back 6 months to where we were on that, I think that is a very significant achievement. And I mean, the really important bit about that is we've tried to understand what are the lessons that we can learn from that so that we can apply them in other areas, because I think we've recognized there were specific actions we've taken through that, and I'm sure Dan is happy to talk about them, but have led to a sustained improvement in that position. And how do we then try and take those into some of the other areas? One of the areas we've talked about is around how do we make sure, you know, where there is learning to be shared, for example, with how we do SIs, can we learn something to share some of that learning amongst the teams? I will leave it there in terms of just the summary positions on the IPR in terms of the core metrics. The national standards report is also in there where we sit against the sort of national KPIs. I won't rehearse what's in the pack. We continue to achieve the ones that we have been achieving. There's been no deterioration in those. I think it's fair to say we continue to remain challenged in the IAPT service, but I think it's worth noting that is very specifically being driven at the moment, in particular last month, against the Brighton IAPT service, which, while we're still looking into it, does look very much like a position being driven by the younger demographic patient cohort who during the course of August may well have ended their treatment sort of while they leave university and go back to their other areas. We've also recently had a new system implementation within the Brighton team that has probably contributed to a drop as well. So that's one of the areas that we will be focusing on to try and recover that position, because up until sort of last month, we were delivering our locally agreed target, recognizing that that is not the national target, but it is a local decision and that where we made around our investments, and therefore we agreed a local set of targets. So that's what we will be focusing on in terms of from that perspective. I will stop there. John, I don't know if there was anything else you wanted to add particularly, otherwise we'll take some questions.
Thanks very much, Usman. Very little to add because I think you've covered off the majority of it. I was going to mention IAPT, but you discussed that already. I know we've talked about it already, but I do think it is worth highlighting the challenge around medically ready for discharge. So whilst the numbers of patients, the total numbers of patients are not the highest they have been, I would like to draw colleagues' attention to the average length of the delay, because that is something that has changed. So you would have seen in the pack that the average length of the delay at the end of August is 90 days. That is not the total extent of somebody's length of stay. That is just the length of their stay of which is delayed. So you can see the inevitable knock-on impact in terms of accessing patients to hospital in a timely way. Usman has already mentioned CYP, eating disorders. The relationship between medically ready for discharge and length of stay, I think, is important to bring to the board's attention. You'll notice on the national standards slide, we currently continue to benchmark well against adult length of stay for patients. That metric is on discharge. So it's patients on discharge when they have been in hospital for longer than 60 days. We don't benchmark so well for adults for 90 days. There is a direct correlation there between medically ready for discharge and length of stay. And then the final thing, Usman, I know you touched on it again, but I do think it's worth bringing to the board's attention. The final slide around patients who've been waiting for longer for 52 weeks. Colleagues will remember we've had many detailed presentations here around the whole of our waiting times program. And of course, we're just focusing on here in this slide on adults who've been waiting, or patients who've been waiting for over 52 weeks. And it is a positive picture with the exception of adults waiting within our West Sussex services for ADHD assessment. However, what this slide doesn't show us is the wider piece around the longer term neurodevelopmental waiting times that we have. Again, we have discussed those here before. So it's fantastic that we're seeing reducing numbers in our CAMS services, both in Sussex and Hampshire, and in adult eating disorders, particularly because of the morbidity, the comorbidity with physical healthcare issues. But I do think it is of note that we continue to have large, lengthy waiting lists for adults with neurodevelopmental disorders. Chair, that's it from me. As Usman said, either of us is very happy to take any questions.
Okay, well, as is always the case, there's quite a lot in there, so I'll see how we go and try and segment that a little bit as we go along. Kevin.
Reporter, as everyone knows, extraordinary amount of detail and really some really heartening things in there. I've got sort of two questions, one possibly quite quibbly and maybe a bit disappointing, and the other hopefully a bit more substantial. When it comes to complaints, is that measuring according to the new target of 35 days, and does it backward chain to the old target of 25 days? And is the improvement in part down to the changing target or to improve performance, or both? That's the first quibbly question. And the second question was about, you mentioned West Sussex, and I love the granularity of this work as you get into how the various divisions work. And you know, in terms of learning, it seems that we've got some high and low performers, and hopefully they're learning from each other. But West Sussex does seem to stand out in terms of quite a few reds, if you like, on that report. So wondering if there's a particular West Sussex QPR improvement plan. So
okay.
one's more.
Okay, so Dan, do you just want to pick up the point on the metric, please?
Yes, and I don't think it's a quibble at all. So we are now working towards 35 working days. So that's what we're currently reporting against. We could get data against the old target. We've met the old target as well, at the same time as having reduced the backlog, which had got to a high of 73 overdue cases 6 months ago. The other point I'd just make briefly on complaints, in the narrative, it talks about the fact that we've maintained quality of responses. They're my words, which reflect the quality improvement work we've been doing, which incorporates both timeliness and content. That said, reflecting on our earlier conversation in the meeting and your point, Chair, I don't think it's for us as an executive or me specifically as the exec lead to make that assertion. So I need to consider how we reframe that and draw upon complainants' actual experience.
Okay. In
Chair,
terms,
do you want me?
I beg your pardon?
Oh, sorry, I was going to say, Chair, do you want me to cover off the West Sussex question, or did you want to take some more
I'm
questions first?
very happy for you to cover off the West Sussex question. Thank you.
In the response, just say I'm conscious of the commissioning context as well, that it may well be a commissioning or system response as well.
So, I mean, I think there is probably a really complex answer to this question, given that, yeah, I think there has been historical, I think, differences between how various parts of the county before, when it was still subdivided, may have commissioned services. I think the reality is if I look at two particular metrics, and I think one internal, one external, it gives some sense of where we are in terms of the challenges within our West Sussex system, and therefore you're right, what is the specific actions we need to take? So from an internal perspective, West Sussex, and by and large, all of West Sussex, although predominantly within coastal West, is where we have our highest vacancy rates. So we struggle the most to be able to recruit into the coastal West Sussex area, and even in Northwest Sussex, we really struggle to recruit there. And I think the reasons are quite different, but the impact is the same in effect. We are reliant on a high number of agency staff, quite often with quite churn rates, and therefore that then leads to the impacts that you will see in those particular KPIs where having lead pracs, etc., is important. On the MRD position, I think it's fair to say we know we have challenges in the West Sussex system. We've been discussing with West Sussex County Council around what else can we do, and Jane alluded to her conversation earlier as she talked about her CEO's report around how do we move sustainably rather than sort of getting into this individual patient moving today and then another tomorrow. What's the next 2 or 3 year plan to get to a sustainable position? And I think there's going to be no easy answer to that. We all understand the context that all local authorities have operated under. Some have managed for a whole set of reasons to be able to manage it slightly more effectively than others, relating to how resources have been deployed, but that's something we're going to have to proactively work with them, and we have been going forward. But I think, yeah, hopefully the report, I think, as you said, allows you to get into that level of detail, which I hope colleagues find it useful.
Yeah, thank you, Usman. Jessica.
Hello. Apologies again for I haven't read the papers. This question may have already been answered, but with regards to the ARFID situation, which I'm not entirely sure exactly what the ARFID situation is, but and the delayed discharges in West Sussex, how much of this do we think is due to the difficulties in identifying ADHD and autism across the board?
I feel like I should defer the second part of that question to a clinical colleague of mine. In terms of just ARFID, just to be really explicit about that, within the Hampshire services that we are commissioned for by the Providers Collaborative, within that there is, I think ARFID stands for the Avoidant of Restricted Food Intake Disorders, which isn't necessarily also part of the commission service elsewhere, and that is a very specialist area. There are only a limited number of staff who are actually trained to be able to carry out those assessments, and therefore that is where the backlog has developed. So when I talk about those numbers, when we strip out the ARFID patients, the performance is the same as it has been in Sussex or compares favourably with that. It's because of that particular definition, well, that particular cohort, and there has been a significant amount of work to try and improve that position. I think the work continues. I think the position is significantly better than it was late last or early last year, and I think it's continued to improve while we work together with colleagues to understand what else we can do to try and address the backlog, but also then move into a better position going forward. In terms of identification of ADHD, I might look to colleagues, maybe Jane, to answer that question.
Okay, thank you. I'm going to go to Jane and then I'll go to John.
So Jess, I think the whole area of neurodiversity, ADHD and autism is under-recognised and something that we are in a very early stages of our understanding as a trust. I think it is something that certainly myself, and I'm speaking because I had a long conversation with Pete, our Chief Medical Officer, yesterday about this, about how we use our academic, our university hospital status and our academic colleagues to think about how we become a centre of excellence and think about how we look at this in a lot more detail, because we can make lots of assumptions and have lots of ideas, but it's not grounded in data at the moment or a true understanding, nor the skills in the workforce fully. So I think it's an intention and it's early days, and certainly as our university partners, we are very open to thinking about how we progress this area, because I think it's not just on the RFID side of things, it goes across our crisis pathway, our inpatient services, our community services, and it's integrated throughout all of our services. So we want to think about it more as a trust-wide strategy rather than just an individual pathways.
Oh no, completely understood. Thank you.
Okay, thank you, Jessica. John.
Thanks, Peter. Just to Jessica's specific question around, I think you're describing the relationship between patients who are medically ready for discharge and who may be experiencing neurodiversity. It's absolutely a link. I don't have a number to be able to offer you this afternoon, but when we look at the care and support packages that are required for patients with the most complex level of needs, it's often in the context of neurodiversity alongside suicidality, high risks of self-harm, contexts around eating disorders. So yeah, it's absolutely a link between those folk who remain longest in hospital and possibly those who have the poorest outcomes in doing so. And that's not just unique to West Sussex, but obviously the numbers are greater there.
They almost certainly have concomitant physical health issues that further make the social care picture more problematic.
More complex indeed.
Right. Thank you. Thank you. Dinesh.
I just going back to what Usman was saying earlier and something that Jane alluded to, have we been thinking about in workforce planning, but the potential role of physician associates and nurse specialists and nurse practitioners, and would that help us deliver services which are much more prompt? So just a question, really. I don't know the answer.
Would you like me to answer it, Peter?
I was just seeing who volunteered, Teresa.
Okay, so absolutely. There's two key pieces of work that are in train at the moment. One is the publication of the nursing strategy, and in the nursing strategy there will be commitments to new roles and multi-professional roles as part of that. And then the second point is that we are conducting an annual establishment review at the moment, and I have no doubt that the recommendations that will come from that will be about competency-based recruitment, replacing in some parts traditional roles. So yes, Dinesh.
Thanks, Teresa, really helpful. So I'd appreciate just exploring something if that's okay. So it's fantastic if we're starting to get our response times to complaints better. And obviously it's even better if people feel that they're being listened to and that we're then acting in a way that they find helpful. But we all recognize that that's downstream. And arguably, when you look at where things get out of hand in organizations, where litigation ensues or regulatory intervention happens, it's often because there hasn't been proper engagement with the patients, there hasn't been co-production, there hasn't been proper engagement with the families. Not always, but it's quite often, it's noticeable how often that's a factor upstream. And yet here we are, we're looking at care plans not being recognized as having been done. We're looking at risk assessments. We're missing that. And it feels like these are really fundamental bits of the jigsaw when it comes to the relationship with patients. And it feels like we really, really struggle to get these basics onto a better trajectory. How is it going to be different? Does it matter? And if so, how's it going to be different? I just leave that. Jane.
Thank you. So we had a long conversation about this in the quality performance reviews last week. And it's much like I was just talking about earlier about the supervision and appraisal. It is why is it important, and about shared decision making with patients and moving from listening and doing to actually going down the downstream, as you say, to actually preventing complaints in the first place, because people are really involved in their care plans and really involved in their risk assessments. And it's going to be a cultural shift that it's going to take some time, and it isn't just about chasing the numbers. But at the same time, we have to have a recovery trajectory and get to grips with it. It is not good enough that we have so many people without a risk assessment. It's not good enough that we don't have anybody without a care plan, and we haven't got the time to wait for the cultural change. So it's a dual running thing, I think, about how we instill the values of the importance of these things at the same time as really pushing the performance.
Okay. When do you think that might happen?
Well, we've got recovery trajectories being worked on at the moment, and they're coming to the QPRs next month with a plan with how they are going to achieve it. And we've been very clear that we're holding them to account on the outcome, not on whether they've done all the actions that they say they're going to do. So we'll be looking at the percentage going down and up, not down, up. The percentage is going up. And improvement. So I would expect almost immediate from the next month, when we've agreed those plans, that it would start going up month on month.
Okay, thank you. Jo.
Thank you. It feels like we've come full circle in terms of the discussion we were having earlier about managers, regulation and training for leadership. And I think the question or the challenge you pose, Peter, is, yes, I would say my experience of talking to staff on site visits is that all of them would agree that it's important that they do those things. But in recent visits, particularly when I've accompanied Teresa, there is something about how some of the staff that we have met view professionalism and how they define professionalism. And I think as part of the culture, my understanding of it, on going away and reflecting, is that yes, it's about culture, but it's also, there is a significant conversation to be had across SPFT in terms of what does professionalism mean? What does it look like? Because if professionalism is that when something isn't done or falls short of the standards that we expect, it's not something that you escalate to your manager. It's something that as a professional you're accountable for. It's something that you can do something about, and then you can apologize later because you didn't ask for permission. And that there's quite a lot of that. And I think we keep seeing little bits of evidence of that across the trust, certainly as we go around on some of the site visits. And it's how we pull all that together to really create the shift in the mindset of, yes, we're tired, we're exhausted, but actually if we start to get it right and start to feel better about our performance, it would actually then make us feel more energized and feel as though we are professional and we are delivering at the standard that when I go home, I feel I've done a good day's job. Does that make sense?
It does make sense. Thanks, Jo. So I'll go to Dan and then Teresa, and hopefully we can pick up both aspects.
I mean, I would say one part of the jigsaw, and it's only one part of the jigsaw, is that work on and that focus on early resolution, early conversations, and there are two ways that needs to happen and is happening in practice. You know, on one hand, the conversations weren't routinely taking place before we issued a formal complaint response. It now is happening routinely, because that's absolutely been championed and been made clear by the CEO as an expectation. But more broadly, it's absolutely right that we focused on complaints performance. The work ahead is to continue the improvement on that performance and get out into services alongside clinical services and clinical staff to support the early resolution of concerns and to support those early conversations.
Great. Thank you. Teresa.
Thank you. So just to the point about care plans and risk assessments, and to Joe's point about professionalism, professional code of conduct will require you to view a care plan and a risk assessment as a fundamental of care and that you cannot operate without them. So if I'm a lead practitioner in a ATS, that without a care plan, what is the treatment that I'm delivering to that patient? And so to Jane's point, the trajectories through the QPR are absolutely critical, and we need to be holding those standards, recognising the context in which people are working, but this isn't a negotiable. And I just felt that it was really important to say that in terms of the importance that care plans and risk assessments are an absolute fundamental of care, and there is no excuse not to have them.
Thank you. Is there anything else on the integrated performance? I was saying integrated care report. Sorry, integrated performance report. Okay, so and I think this is something we will come back to, and I think what we'll do is, particularly when we're next together, I think it would be worth having a conversation about actually how do we get into a conversation as a board about some of this. The cultural work that we're doing alongside the quality improvement work we're doing, so we get things that we all are on the same page in terms of what our approach is and where our assurance is going to come from, that we've got the right plans in place. I think that would be, it feels timely to do that at this point in the year, in relation to some of those performance issues. But thank you for the report and sharing the challenges with us. And I think that we have understood if you like, the context and the work that's going on to try and address some of those kind of particularly long-standing issues. Can I now move us to the Finance and Investment Committee report, please? Simon, I think you're helping us out with this afternoon.
Absolutely. I will take the report as read, and I guess the key thing really is to note the month 5 report, which shows that year to date outturned 6.2 million deficit against a planned deficit of 3.2 million, and that obviously some real progress is being made against the recovery plan, but there are also some pressures such as the unfunded pay award which are contributing to that. But I think the other thing to note is that we recognise that there is a risk around some of the unidentified cost improvement programme. So those would be the two things I draw attention to, assuming that the report has been read, but happy to take any questions.
Okay, thank you. Are there any questions specifically for the chair of the Finance Investment Committee, or shall I move to the finance report itself? I think we're fine. Thank you, Simon. We'll move to the finance report itself. Usman.
Thank you, Chair. So I will not go. I will take the report as read, so I'll go through every single slide. But just to draw out some key issues. So as Simon reported, the year-to-date overspend about 3 million pounds. I think it's worth highlighting that year-to-date 0.7 million of that relates to non-pay inflationary pressures, which were over and above the level that we were funded to address. In particular, that comes through in terms of energy inflation, but also food inflation and provisions that were purchased. We also, at the moment, appear to have a 0.6 million pound adverse impact from the National Pay Awards funding, where we don't believe that has fully covered the cost of it to us. So in total, that 1.3 million pounds, so sort of circa half of the current year-to-date overspend, is being driven by sort of what I would describe as things that are out of our immediate control. That's not to say we won't have to address them as we move into next year, but at the time that we set the budgets, they were not necessarily things that we were aware of or could set plans for. With regard to the balance of the overspend, so I think as Simon set out, the recovery plan has been very successful in terms of historic performance, but year to date, we are still £1 million short against that. I think it is worth highlighting that year to date, we have delivered £6.2 million worth of savings. So that is in the first 5 months of the year. And I know I have said this last month as well, but I will just reiterate that is at £6.2 million, that was the total savings we delivered in all of last year. So I think I'm just using it as data to evidence that the recovery plan, I think, is doing what we set it out to do, where we've got the underspend, in particular, a significant amount of that underspend related to under delivery in Q1, which we knew was going to be a risk. But if you look at the position over the last 2 months, we're much more in line with the plan. So that sort of from an overall perspective, I think there are a couple of things I just do want to highlight. A key element of our recovery plan was in effect what we called around our patient flow program. A significant component of that is around the use of the independent sector beds, and our current trajectory does have that reducing to 35 in Q4. And I think it's worth highlighting now for the board that we are currently in discussion with our system partners to understand what the impact of that would be, given the challenges that we are already seeing, and that if we were unable to enact our financial recovery plan as we set, then how would that be mitigated? And that is not just a decision for us, but that's a decision across our system and how, working with our partners, we would manage that. In terms of the other big element of our program, it was focused around the agency sort of spend and reducing that. As I alluded to earlier in the performance report, agency spend as a percentage of our total pay bill does continue to reduce. And I think the controls that we're putting in place are having a positive impact. It's absolutely true that in August our spend did increase, but I think that was planned in terms of the run rate. We expected it to increase in August given the higher annual leave requirements and some holidays, and also the continued high rate of vacancies. The net joiners number has fallen last month, and I think that then corresponds to higher use of agency staff, which is what flowed through, but that was kind of in line with what we expected. So that range of incentives I talked about earlier in terms of being able to attract permanent staff, we're in particular trying to target the agency staff who currently work for us. Clearly, I will say that is in line with all of the rules that go with that in terms of contracts with those agencies. So just to be clear, we are not poaching staff, but we are offering our most attractive set of proposals and incentives to those staff who currently exist. And the simple reason is that it's because that's where the supply currently is. So we have to recognize that, and that is the fastest way to increase our permanent numbers, but clearly in line with all of the framework rules around use of recruiting people who are currently on agencies. So again, I won't go through all of the finance details. I mean, the numbers are as they are. I won't repeat what's on the tables in terms of the 3 million overspend, 6.2 million actual. I guess the focus that I want to just draw to the board's attention is around the financial recovery program. At year to date, we've done 87%. We know it gets harder across the balance of the year. So Q4 in particular, that as you'll see from the graphs that are set out in the finance report on page 6, it does get significantly more challenged. And I think it's fair to say that there is risk to our planned position, and that is risk that we continue to discuss with internally through the Finance Recovery Committee, through all of our regular meetings, but also with our external system partners. So the focus for the balance of the year is how do we try and accelerate the programs that we currently have so that we can aim to deliver that level of savings, and what are the other mitigations that we potentially have to be able to mitigate what we think will be some shortfall potentially against the scheme. Just to the reason I say that specifically is for everybody's sort of memory and for new colleagues who joined us, about £4 million of our recovery programme was the stretch target that we agreed to at the sort of towards the end of the planning round, recognising the importance of trying to achieve break-even. That target was tied to being able to reduce our medically ready for discharge number. And as we have talked about at length through this meeting already at various points, that is not reducing. And that is very much an action that requires all of our system partners on board with us. So I think we are trying to understand, if we aren't able to do that, if the MRD numbers don't decrease, what do we do instead? How do we help mitigate that? And how do we work with our system to understand what the consequences and impact of that will be? But I think it's fair to say both that stretch CIP and the national inflationary pressures that we are seeing and the pay award will remain significant challenges for us.
Yeah.
And risks as we go into the sort of second half of the year and potentially to our year-end outturn. And that's it from me, Chair.
Thank you. That was implied, but thank you for making it explicit. Thank you very much, Usman. Are there any questions for Usman? I have one, but I just want to see if the board have got questions first. Okay, Usman. So, I mean, you and I have, with colleagues, have rehearsed the idea that we do finance last at board because we do quality, then we do performance. And if we haven't talked about finance by then, this should be, if you like, a sweeper position by doing it at the end. I'm very conscious of the level of risk that we're exposed to, both clinically and financially, and which you are bringing to our attention. I'm very conscious that you and Jane in particular are going to be under a huge amount of pressure as we move into Q4. And we saw that last year, and I see no reason why this year shouldn't be the same, if not even more pressure being applied on us. So I think it would be good between now and our next board meeting to think about how we bring that understanding of risk to the board and how we can make sure that the board fully understands the risk that we're carrying and what the potential mitigations are as we move in. And I would suggest we do that at the next board as we move in, before we move into Q4, because, you know, once you're in Q4, it's the kind of, you're just waiting for the dominoes to fall, aren't you, really? So I think we could look at where we position, what it is we're bringing as the finance report to the next board, but also where we position it in relation to some of the other items, so that the board can be much clearer about the choices it might need to make to meet which of its obligations. Okay. Does that sound? Yeah. Do reframe that. That was meant to sound more like a question than it did. Sorry.
No. That can make complete sense. And I think our intention, we are currently, as you'd be expecting, working through what the forecast for the year end looks like at the moment, with all the risks that we've discussed, and therefore what our potential range of mitigations are. And so we will bring that both through the finance committee and then also to the board. And then I think it would be helpful to have that conversation perhaps sort of earlier in the agenda, so that when we then
I think that might be an occasion when that feels very appropriate to do it that way, to do it that way around. And if colleagues are, I mean, we'll work this through in terms of exactly what that means, but are people comfortable with that as an approach? Yeah, it appears we are. Thank you. I think we'll leave it there for today, unless anyone has anything they want to. No, I think we'll leave it there for today. I think we're very aware of the risks that you're starting to highlight, and I think we do need to dedicate some time just to make sure that we can then work through what those mitigations are. But thank you for your candor and clarity this afternoon. It's really helpful. Can I now move to the Audit Committee report, please?
Thank you, Chair. Can I take the report as read? And in that case, just draw your attention to the key issues and risks to escalate to the board item. An update in terms of our external audit retender. And Usman, Corinne and I have been discussing this quite a lot, and then you and I discussed it, I think, on the 26th. Corinne and I have been trying to speak today, and we haven't had a chance to catch up. And do you have an up to the moment update, because I don't, in terms of what
I do, Joe.
Right.
I'm happy to give the update. Do you want me to do it now?
Yes,
can do
please.
It? Yeah.
Please.
So I think, as colleagues will be aware, we conducted a procurement exercise to get a new external auditor. And for new colleagues' benefit, that is because our existing auditor, KPMG, had given us notice last year. But because we were unable to secure a replacement for them, they agreed to stay with us in effect till November this year, so to see us through this year's audit, which they have done. We then ran a procurement exercise during the summer. Unfortunately, no audit firms in effect expressed an interest to carry out that work. I should say that is not unique. It is an issue at the moment across the whole of the NHS. There are a number of trusts at the moment who do not have external auditors, and a number of others who are currently in the middle of procurement and unable to secure auditors for external audit.
And sorry, Usman, and I think we should add that this is an issue that we knew, and National Audit Office flagged up over 2 years ago, and we flagged up to NHSE. So it's not that there hasn't been action on our part.
No, absolutely. We have been continuously raising it and trying to work with partners to make the audit offer as attractive as possible to potential partners, working in partnership with QVH, Queen Victoria, and SPFT. However, as of today, the current position, the latest position is KPMG are still saying they are not able to carry out or extend the contract. They simply do not have capacity. They do not have the people to do the audit. And we have not had any firm expressions of interest from anybody else. We therefore potentially are in the position that as we enter Q4, we would not have an external audit partner. We have raised that and updated NHS England off that position again this week, so they are aware and seeking their support for what else we could do, because as I said, and I just want to reiterate it, we have, as Joe said, we've been raising it with them continuously. It is an issue not just for us, but for other organisations as well. I am working with Corinne and the team to identify what other sort of in extremis options we would have, because clearly not having an external auditor puts in a really difficult position in terms of sort of, well, just from a governance point of view, but in terms of practicalities of being able to close down the annual accounts and getting our things signed off by Parliament, as we did this year through the AGM. And we will provide an update to the next AC and then to the next board on where we will go from there. But clearly, given the time to the next board, we may have to ask for members' sort of views and opinions ahead of time if required, because ideally the next year's audit would actually begin sort of in early January. So external audit would in effect begin doing their initial work in Q4, during the prep work. And if we don't have anybody, that will be a real issue for us. So we'll continue to sort of work on it, but that is the current position as of now.
Okay, Joe, do you want to come back in?
Yeah, thank you, Usman. And Usman, can you confirm the position is that until we have resolved this, KPMG remain on the record as our external auditors?
They do, and that is the official position. That is how it maintains. However, I have to say, there are a number of trusts now nationally where, despite that being the official position, they do not have audits. The firms are unable to carry out their audits, and they're in effect, what the firms are saying is, we don't have the people to carry out the audits. So that's absolutely correct, Joe. But I think the market is very, very stressed at the moment in terms of that audit market, and we'll continue to work with colleagues to identify ways to try and mitigate it over the next 4 or 5 weeks. I think it's fair to say an enormous amount of work has happened over the last 2 or 3 weeks to try and find a resolution to this position.
Thank you.
Okay, so sorry, Joe.
Yes, I was just about to invite any questions. No?
Okay, so I have a question. Can I just be clear, Usman, what it is you think you might need from who between now and the next board? If it's okay, Chair, I will, well,
in terms of what we might need between now and the next board, given the timing is, if we were able to come up with a short-term solution to find an auditor for a year that hasn't gone through, in effect, the procurement process, and in the sign-off for that, because theoretically the appointment of an auditor would require the Council of Governors. So, but it could only go to Council of Governors after we have approved it to go there. So we may need to hold a formal virtual meeting to say this is the this is the people we would like to appoint.
Fine. Okay.
But I'm happy to pick it up with you outside of here. If that's easy.
I think so. I think we just need to work out what the steps are, because it depends a bit on the contract value, and I don't want to get into that in a public meeting. So we'll do that outside. Okay. Joe, sorry, back to you.
No, fine, thank you.
Does anyone have any other questions for either the chair of the audit committee or for the chief finance officer? No. Okay. Thank you very much for that.
Thank you. Thanks, Usman.
Thank you, Usman. Any other business? No.